Thank you, everyone, for having me. Great to be here. The name of the company is Solvein. I'm the founder, CEO. I'm also a practicing interventionalist, and I suppose that is a conflict, but anyhow. So meet Jane. Jane has veins. Jane has pain. She has pain in her legs. She has pain in her pelvis. Venous disease is super common. We've already talked about the incidence of lower extremity venous insufficiency. I think even more forgotten than lower extremity venous insufficiency is pelvic venous insufficiency. And it's also very common, underdiagnosed, undertreated. And not only are the veins forgotten, they're also getting the hand-me-downs, right? You make something for the arterial world, and then you shove it in a vein, and arteries and veins have completely different behavior and anatomy. So valves are the issue. We all know that. They're the same issue in the pelvis. So the problem is that we've made great advances in the treatment of superficial venous insufficiency, but there are still some shortcomings. Thermal works great, but too messing patients is irritating for the patient, and it's also time-consuming and annoying for the physician. Saline shortages, lidocaine shortages, et cetera. You can have hypersensitivity reactions and infection with glue, and you can get non-target embolization, thrombophlebitis, and trapped blood with microfoam. So our current interventional option is just kind of breaking down into the shortcomings again. Too messy anesthesia is painful. It takes time. If you're doing 20 of these in a day, 20 times 5 minutes is 100 minutes. That's time you could be doing something else, let alone the pain for the patient. And with the glue, the issues that arise, and again with the Varithena. And the other thing to consider here is that if you're making a technology, I think your goal really should be to treat as many patients as possible and get them the advantage of improving their medical condition. And there's just so much venous disease, and there are only so many of us subspecialists. So really a lot of this disease is being treated by non-vascular physicians, and the simpler the technology, the more scalable and adaptable it is. And so with microfoam, you really do have to be quite good with ultrasound and have a lot of dexterity, and it does have limitations. So I think the next frontier is a non-thermal, non-tumescent with no permanent implant, and that gives you control. And combining the synergy of a mechanical and chemical ablation will improve, because if you're using a chemical only, you're getting thrombosis, hoping for fibrosis. But really, if you start to follow your microfoam patients out long, you do get some recanalization and recurrence. So the original version of mechanochemical ablation, which came out a while ago and is great technology, does have certain limitations. It can get stuck as it's spinning, you get tethered, and you don't get complete denudation of the endothelium because it's like a tether, it's pushing that wall away. And you don't have control of where the medication goes, so you can get a DVT. And remember, the blood is the enemy. Not only does it deactivate polydocanol, it also causes thrombosis and pain. So a bloodless field or a near bloodless field is sort of like the holy grail. Here's a little animation.
The following is a demonstration of the Solvein procedure. This is for the treatment of a saphenous vein. Here we see 6 French vascular sheath access obtained to the greater or short saphenous vein, and the catheter is introduced under ultrasound guidance. The balloon is partially inflated under ultrasound until the balloon and the nitinol wires, which are draped over the balloon, are in contact with the inner portion of the vein wall. The catheter is advanced upwards towards the saphenofemoral junction, causing mechanical injury to the endothelium of the vein. Once the end of the target zone is reached, typically a few centimeters below the saphenofemoral junction, the balloon is further inflated to an occlusive volume. This is confirmed under ultrasound. At this point, any blood remaining in the saphenous vein is aspirated via the infusion, aspiration port, and a physician-determined substance. A medication of choice by the physician is instilled, in this case a foam, to help with completion of the treatment. This foam is tracked under ultrasound so that it is instilled into the portion of the vein that you want to treat. The balloon is left inflated for 2 minutes. After this 2-minute period, the balloon is deflated and the catheter is removed, and this concludes the Solvein procedure.
So it's simple, obviously, hard to mess up. You're getting rid of the tumescent, which is good. Getting rid of things like hypersensitivity, thrombophlebitis, pain. And these patients have multiple lesions, and they also have family members that have multiple lesions. So if there's a good patient experience, there's sort of a multiplicative effect. It's fast. 30 minutes is if you're slow, and that's the entire time. In the clinic, my time would be 2 or 3 minutes, which is fast. And there's less risk and less complications, which is obviously a good thing. Regulatory pathway, our predicate is Clarivane. Our indication for use is the same as Clarivane. Since it's a low-risk device in the periphery with a predicate, we don't need a human trial. The code is Clarivane, and we have to do a small acute animal study and some benchtop verification validation testing, so relatively quick pathway. Submitting in the summer to 510K to FDA. We've had meetings and pre-subs and whatnot, so that's all in writing. Great team. Mahmoud Razavi, Daniel Hawkins, founder of Shockwave, Jeff Carr was CMO of Enclose, Greg Walker, we all know. Andrea is the head of the bioengineering firm down in Mexico that's doing some of the development work. Joel is helping us with business development. Curdy was actually the SVP of Venous, which was the original RF company, and Shockwave. And Jim is a physician who then started a CRO called Lycron, similar to NAMSA. He actually created the original model for venous disease, and invaluable source of information. That's it.
So what kind of foam do you use?
Again, up to the physician, and I think the reality is that, one, the balloon is making contact with the vein wall and distending it, so you're getting circumferential denudation. You're inducing vasospasm, and then you're aspirating out any blood. So by the time you get there, the vein is so small that you just need a little bit of 1% polydocanol, in my opinion, but you can use SDS as well.
What about the thigh perforators?
Yeah, so really good question. One, when you're steamrolling over the perforator saphenous junction, it vasoconstricts the same way sometimes you use epi to cause vasoconstriction, number one. Number two, you pull a negative vacuum. Number three, it's vasoconstricted. Number four, the foam comes distal to proximal. And physician compounded foam is more forgiving than polydocanol microfoam. So in all my years of doing physician compounded foam, I haven't gotten a DVT. Of course, if you're overly ambitious, you can get it. And if you have a ginormous thigh perforator, just put the balloon below it. Yeah.
Just an anecdote for you, that the person who introduced injection sclerotherapy was a man called Fegan in Ireland about 60 years ago. And he noticed in the great saphenous vein, which he would routinely do, that you had to have compression afterwards or it didn't work. And I wonder if you might remember that as you go through this.
Yeah, it's a great point. I mean, we're definitely going to put the patient in compression. But the reality is that when you're inducing thrombosis and then hoping for a conversion of thrombosis to fibrosis, the key is mechanical injury, hence why physician compounded foam standalone doesn't work all that well, and you need the mechanical combination. And frankly, Varithena doesn't work super great in really big veins for the same reason.
Just a thought.
Yeah.
Two things there, right? You have a balloon there,
Yeah.
holding it for 2 minutes, and how
Correct.
long does it take for foam to actually work completely?
We typically recommend 2 minutes of compression for Varithena. So 2 minutes of compression here or leaving the balloon up. And then there's a second generation technology with a proximal balloon that you can use for pelvic embolization, because obviously you don't want the foam to go up into the IVC.
Size limitations on the size of your diameter?
14, which is supermajority of veins. If you have a jumbo 20 centimeter vein, I point you in the direction of RF. That's a great question. That's like bringing a cutting balloon, and it's not, all due respect, it's a compliant balloon, it's a soft balloon, it's a volumetric balloon, it's not a hard balloon. So actually it goes to different diameters, and that's why you want the abrasion elements to have the ability to adopt to different sizes. So you can go from 3 or 4 millimeters up to 12 millimeters, because again, it's a compliant balloon, and it's a non-silicone, non-latex compliant balloon. Silicone and latex are a huge pain in the butt. And it was actually pretty cool engineering to figure out how to make a compliant balloon without latex or silicone that's thermally bondable, because you have to glue with adhesive silicone or latex to a catheter, which is also a pain, because then FDA makes you do leachability testing, and that's a drill to the head.
That wire that injures the endothelium, I mean, do you have evidence of that?
Yeah, we have animal studies. I think we've done 12, and the reality is that that's an old version. The new version is still under the covers because we're getting our patents on it, but there's 4 abrasion elements, and they're oriented in a fashion so that you get 360 wall injury. So, great question.
This is just for the saphenous system, right? You can't use it for any perforation.
You technically could. I wouldn't necessarily recommend it. I mean, I use Varithena for my perforators, but I do a lot of Varithena. Yeah, you could position it in the perforator at the junction, advance it, cause injury, and then inflate, and then aspirate and inject. But kind of easier just to use an RF stylet. In my opinion, but you can use anything anywhere, but a little challenging.
Okay, I think in the interest of time, we'll thank our speaker and move on.
Thank you so much.